a civilization or a scientific community for that matter in which there is no continuous controversy about important issues is on the way to totalitarianism and death. So controversies kindle interest, and that's the theme of our next session, controversies in regional anesthesia. And Dr. TVS Gopal will be speaking on laparoscopic surgeries. Would you prefer regional anesthesia in such a situation?
Good morning. I'm back again for one more lecture. This will be my last for the session. This is definitely a controversial topic. Would you prefer regional anesthesia for laparoscopic surgery? And there are proponents of regional anesthesia, there will be proponents of general anesthesia. We'll look at the data and the evidence as we go along. The debate between general anesthesia versus regional anesthesia for laparoscopic surgery has been raging on for some time and has been begging answers. There was a time when the accepted dictum was that general anesthesia is the anesthesia for laparoscopic surgery. However, proponents of regional anesthesia tell us that this dictum is just a concept of the past. They will tell you that though general anesthesia affords clear-headed and rapid recovery from anesthesia, you cannot extend the post-op pain relief into the post-operative period, and you cannot also guarantee an emesis-free recovery. However, having said that, we do know that when you do laparoscopic surgeries under regional anesthesia, you will have to ask the surgeon to moderate or modulate the technique. You will have to optimize the laparoscopic equipment, and the anesthetist also needs to exhibit some sort of a creativity. Therefore, the question we should be asking is it worth doing, not whether it can be done. These are the absolute prerequisites for laparoscopy under regional anesthesia. You must have a cooperative, anxious-free patient, an experienced surgeon who is very gentle with the tissue handling and instruments, not very easy to find. The intra-abdominal pressure should be limited to 10 millimeters mercury or less. The selection of the ports for the insertion of instruments must be judicious, and we cannot expect a huge Trendelenburg tilt with regional anesthesia. This certainly would not be possible when you give a regional for a laparoscopic surgery. So the choice of anesthetic technique for regionals for laparoscopy depends on a lot of factors. Most important is the patient factor. Is the patient obese? Does the patient have systemic comorbidities? Or is the patient extremely anxious? Surgical needs are also important. Laparoscopic surgeries under regionals can be performed if the surgery can be completed in a finite time frame and if the manipulation of the viscera is limited to the minimum. The anesthetist also needs to be cool and composed while handling the demands of the surgeon, the surgery, and the awake patient. Operative theatre setup and post-operative setup are also very important factors that play a role when you make your choice. The advantages of regional anesthesia for laparoscopy are quite a few. You will have a lesser incidence of post-op nausea and vomiting. You have a lesser incidence of post-operative pain because the block that you administer to facilitate the surgery will also extend into the post-operative period, and provided you have not given tons of sedation to sedate your patient will be awake, communicative, and therefore have a clear-headed recovery. And the last factor is definitely true. Since you will be avoiding polypharmacy, it is definitely a cost-effective option. These are the procedures that can be done with regional anesthesia. Gynecological laparoscopy for sure, transabdominal preperitoneal hernia repairs, pain mapping in patients with chronic pain syndromes secondary to pelvic endometriosis, gamete transfer that goes by various fancy acronyms such as ZIFT and GIFT. You can do a gasless laparoscopy, and LapColes, appendectomies, lap-assisted vaginal hysterectomies and total laparoscopic hysterectomies are being performed in various centers. And this is the last mention is an emerging indication, which is if a patient has to have a surgery and is unfit for general anesthesia, you could also do this particular procedure under regional anesthesia. This is how a lift gasless laparoscopy is done. And there is a device which holds the anterior abdominal wall up, and the instruments that are used are quite like conventional instruments. There are certain issues with laparoscopy under regional anesthesia. These include an anxious and uncooperative patient. If you need to put multiple ports, that will be a problem. The surgery, as I said, needs to be completed in a finite time frame. And in a coagulopathic patient or a patient who is on antiplatelet medications, you cannot do a neuraxial block anyway. And if the center is ill-equipped, you would probably not want to do a regional. But again, having said that, I know those of you who are working in peripheral centers will say that because the equipment that we have at our disposal for general anesthesia is rudimentary, we have to do regionals in ill-equipped centers. So that is an argument you can do both ways. The issues with laparoscopy under regional anesthesia are shoulder pain. You can have nausea, hypertension and bradycardia, but that again is a function of the Trendelenburg tilt you will have. Respiratory embarrassment is not an issue in healthy patients, and definitely the risk of gastroesophageal reflux is also there. And that is why you need to judiciously sedate your patients so that the patient will be able to maintain his or her own airway during the procedure. These are the advances in laparoscopy that have facilitated the performance of more and more laparoscopic surgeries with regionals. That is high-definition monitors, high-definition cameras, the use of a thermoflator to inflate the abdomen with carbon dioxide. What it does is it heats up the carbon dioxide before it's passed into the peritoneal cavity. This is absorbed much faster and the incidence of shoulder pain is much lesser. And mini laparoscopic equipment has facilitated the use of smaller and smaller ports, therefore post-op pain is also limited. These are the variety of techniques you can use. You can do a subarachnoid block or a spinal, an epidural block, a combined spinal epidural, bilateral tap blocks, bilateral rectus sheath blocks, ilioinguinal and iliohypogastric blocks are for post-op analgesia. Local infiltration and intraperitoneal local anesthetic spray are again for post-op analgesia, and sometimes for diagnostic laparoscopies limited to the pelvis, which can be done in a short duration of time. So let us quickly review the evidence that is available. This was a study, a small case series of 8 patients, patients having lap appendectomy under a combined spinal epidural. No issues with these patients. This study I would like to dwell upon for some time. This came again from India. It was published in 2008. This looked at about 4,500 patients undergoing a variety of procedures under spinal anesthesia. And as you can see here, the incidence of neck and shoulder pain is quite high. 846 out of 4,600 patients had significant hypotension that required vasopressors. 24 conversions to GA were there, and 255 patients had postdural puncture headache. Now, as you will see in the next slide, though the study was published in 2008, the author used a 24 or a 25 gauge spinal needle. The needle type was not mentioned, and the spinals were performed in L1-2 interspace, which is superior to the conus medullaris. I don't think we would be comfortable doing that. And 3 to 5 ml of 0.5% hyperbaric bupivacaine were used, and that explains why a lot of these patients had hypotension. And nitrous oxide was used for creating the pneumoperitoneum in a few of these cases, and as we all know, nitrous oxide supports combustion. Van Zundert went one step higher, and then he performed laparoscopic cholecystectomies in a small series of patients with a 27 gauge spinal needle in the T10 space. But thankfully, in the last line, he has mentioned that we should advise caution in doing spinals at that particular space, which is proximal, superior to the conus medullaris. This was a pilot study. LapColectomy is under spinal anesthesia, no issues here. And what was mentioned here is that the intra-abdominal pressure was low. And this was a study, interesting study of LapColectomy performed under epidural in 29 patients having chronic obstructive airway disease. And in these patients, the IAP was low and they had intermittent insufflation of the pneumoperitoneum. And a point to note is that none of these patients had a complicated biliary pathology. This was one study where the TAP repair of the inguinal hernia was done under spinals, and it went off pretty well also. This was the interim analysis of a controlled randomized trial wherein a spinal versus general was compared for LapColectomy, and the results are fairly encouraging in this group of patients. So to conclude my short talk, regional anesthesia is ideal for pelvic surgery. It is definitely ideal for lift or gasless laparoscopy. It may be used judiciously for other laparoscopies. We must ensure a low intra-abdominal pressure that does not exceed 10 millimeters of mercury, intermittent insufflation, and we must be able to alert the patient regarding the possibility of post-op shoulder pain or intraoperative abdominal discomfort. And finally, we must be prepared to numb the big ganglion when it is required. So I presented the facts to you, and all those who are in favor of regional anesthesia for laparoscopy, will you please put up your hands? That's a fair number. I think the verdict has been delivered. Thank you.